Welcome to this video entitled Type 1 Diabetes Mellitus in Childhood. On day 1, Vicky, a 6-year-old girl who lived with her mother and 2 younger sisters, was brought into the accident and emergency by her mother. She weighed 22 kilograms and had always been a healthy, active child. The whole family had had colds and fevers over the last few weeks, but Vicky was still suffering from flu-like symptoms as well as having some nausea, vomiting and a recurrent stomach ache. Her mother was concerned because her symptoms were not improving and she appeared to have lost weight over the last few weeks. On questioning, it became apparent that Vicky had been drinking large quantities of water and juice over the last couple of months. She had also wet the bed on a number of occasions, which her mother had put down to her not getting on well at school. Laboratory values for blood taken in accident and emergency were: glucose 22 millimoles per liter. The reference range is 3.5 to 10 millimoles per liter. Blood pH 6.7. The reference range is 7.35 to 7.45. Ketones 5.5 millimoles per liter. Bicarbonate 11 millimoles per liter. The reference range is 22 to 29 millimoles per liter. Her urine also tested positive for ketones, normally 0. A diagnosis of mild ketosis was made presenting secondary to newly diagnosed type 1 diabetes. Question 1 reads, describe the presenting symptoms that lead to a diagnosis of type 1 diabetes mellitus. They include abdominal pain, weight loss, enuresis, thirst, elevated blood glucose, and ketones and glucose in the urine. The onset of type 1 diabetes mellitus is often preceded by an acute viral illness which can cause an autoimmune destructive response in the pancreas, leading to impaired insulin production. Abdominal symptoms are often seen as the presenting symptoms of diabetic ketoacidosis, which is still fairly mild in Vicky's case. The ketoacidosis is due to an excessive mobilization of free fatty acids to the liver, where they are metabolized to ketones. This process is activated by low insulin levels. The weight loss will be the product of several of the presenting symptoms. When glucose levels reach the renal threshold, glucose spills into the urine, taking water with it by the process of osmotic diuresis. The loss of calories in water in this way leads to polyuria, enuresis, thirst, weight loss and fatigue. In addition, there will also be weight loss due to the ongoing viral illness reducing Vicky's desire to eat. Question 2 reads, how do these symptoms compare to a classic presentation of the disease? Could there have been a misdiagnosis? Vicky's symptoms are classic, but in children such symptoms may initially be associated with urinary tract infection, failure to thrive, gastroenteritis or psychological problems. Vicky's symptoms are typical of type 1 diabetes mellitus, with a relatively acute onset of symptoms at a young age following a traumatic life event, e.g. a viral illness. Unlike type 2 diabetes mellitus, there is rarely an association with a family history of diabetes mellitus and the patient is rarely obese. It is uncommon for infants, under 1 year of age, to develop diabetes mellitus, but the incidence increases with age, with particular peaks between 4 and 6 years, and the largest peak in early adolescence. Polyuria and bedwetting in children are often linked to urinary tract infection, and this diagnosis is further supported by the presence of abdominal pain. Because of the gastrointestinal upset caused by the presenting ketoacidosis, there is often weight loss due to lack of eating, vomiting, and the higher urine output. This in turn leads to fatigue and irritability. Consequently, there are often problems at school, which may be picked up by the parents or teachers. However, these problems are then often blamed for the bedwetting and emotional instability. thereby leading to an initial misdiagnosis. Vicky's height and weight have been normal for her age, and the sequence of events alongside the laboratory results have led to the correct diagnosis. Question 3 reads, what are the aims of treatment for Vicky? To obtain optimal glucose control, prevent diabetic complications, chronic and acute, and achieve normal growth and development. Vicky had normal growth velocity before the onset of illness. However, any acute or chronic illness in a child can have a dramatic long-term influence on height and weight. They can thus be used as markers for Vicky's overall well-being as she grows up. The weight loss Vicky has already experienced should be corrected easily and quickly now that the diagnosis has been made. Her height and weight should be plotted at regular clinic appointments on a standard growth chart, so that progress can be monitored. The Diabetes Control and Complications Trial Group demonstrated that tight blood glucose control reduced the incidence of complications, in terms of both microvascular retinopathy and renal failure, and macrovascular, stroke, angina, myocardial infarction complications. In older children and adults it is recommended that intensive control of blood sugar is adhered to, in order to reduce the long-term sequelae of diabetes. The same principle applies to younger children, but greater care must be taken in the implementation of this. Overzealous control could lead to hypoglycemias, and these must be avoided in children under the age of 8 as brain development may be impaired. Glucose control can be assessed by measuring glycated hemoglobin. The HbA1c fraction is commonly measured. It comprises the majority of glycated hemoglobin and is the least affected by recent fluctuations in sugar levels. It measures the percentage of hemoglobin A that has been irreversibly glycated, and its value is determined by the plasma glucose levels and the lifespan of a red blood cell, about 120 days. It can thus be said that HbA1c is an indicator of glycemic control over the preceding 2 to 3 months. Glycated hemoglobin is thus normally monitored on a 3-monthly basis to give a longer-term view of blood sugar control. It is carried out on a finger prick of blood. It has been shown that lowering HbA1c can delay or stop the development of long-term complications. A normal HbA1c is 4 to 6.5%. Levels greater than 8.5% are seriously elevated. The target HbA1c for a child such as Vicky would be 4 to 7.5%. Making the target too tight can be discouraging to children, and so a real balance has to be achieved, but children will often have an HbA1c of 8 to 10%. Children's blood sugars are notoriously hard to control owing to their varied lifestyles and lack of adherence to therapy and a set dietary regimen. It is important to encourage tight glucose control and praise when progress is being made, rather than condemn for being outside a specified range. Question 4 reads, what initial treatment would you recommend for Vicky? As Vicky has significant signs of ketoacidosis, she should probably be started on a sliding scale insulin regimen for about 24 hours, in order to bring her condition under control. The sliding scale insulin method is probably still the most common initial treatment for newly diagnosed patients. The amount of insulin given over the first 24 hours is no longer used as a predictor of the patient's insulin requirement, but it is a safe way to gain initial control of hyperglycemic symptoms. A sliding scale works as follows. An intravenous IV infusion is set up of soluble insulin, that is human actrapid, 50 units made up to 50 ml with sodium chloride 0.9% in a syringe pump, i.e. 1 ml is equal to 1 unit insulin. The giving set is flushed with insulin solution before it is connected to the child, in order to saturate the plastic's absorption of insulin. The blood glucose level should be measured as soon as the insulin is started and the infusion rate adjusted according to the table below, in order to keep the blood glucose between 4 and 11 millimoles per liter. Blood glucose levels should be measured every hour for the first 4 hours, and then reduced to every 2 hours until stable. Once Vicky is stable, her ongoing insulin needs must be met. Pause the video and carefully scrutinize Table 6.1 summarizing insulin dosing using a sliding scale before advancing to the next slide. Question 5 reads, what long-term therapy would you recommend and why? She could start on a twice-daily subcutaneous insulin regimen using a biphasic insulin mix via a preloaded pen. The dose should be based on 0.5 units per kilogram per day, with 2/3 given in the morning before breakfast and 1/3 given before the evening meal. Severe insulin deficiency combined with the physical and psychological changes that accompany normal development through childhood make the management of type 1 diabetes mellitus particularly difficult. NICE do not specify a specific regimen for preschool and primary school children, and just recommend that it be appropriate and individualized to optimize glycemic control. As it is more important to prevent hypoglycemia, which is potentially life-threatening, than hyperglycemia, initial treatment should be cautious. Initial insulin dosing in this age group will usually start at 0.25 units per kilogram per day, but will be higher if there are signs that ketoacidosis has been present for a while. Dosing of greater than 0.9 units per kilogram of insulin per day are rarely required in prepubertal children, but may increase up to 1.8 units per kilogram per day during puberty owing to the increased release of growth hormone at this time leading to reduced insulin sensitivity. As Vicky has shown signs of ketosis for some days, she should be started on a dose of 0.5 units per kilogram per day, with 2/3 being given in the morning before breakfast and 1/3 before the evening meal. A variety of insulins are available for long-term treatment, each with a different time to onset and peak of action, as well as duration of action. The mixed preparations of insulin, biphasic, give a high initial peak and then a sustained level throughout the day when used twice daily. This is a good combination for children of school age, as they have limited support during lunchtime. These combinations have the advantage of providing peaks of insulin around main meal times, breakfast and evening, as well as continual lower levels throughout the day without the user having to draw up 2 different insulins. It is normal to start with a 70-30 ratio, e.g. Mixtard 30-70% isophane and 30% regular, and to make any necessary changes thereafter. Vicky could start by using a pen device giving 7 units in the morning and 4 units each evening, 0.5 units per kilogram per day. These mixes may cause hypoglycemic episodes in young children owing to the short-acting insulin peaks. It is thus essential that as well as eating 3 main meals, Vicky is encouraged to have 3 snacks during the day. Another solution may be for one or both of the doses to be swapped for an intermediate-acting insulin on its own, or to a different ratio of biphasic insulin. If Vicky shows signs of hypoglycemia after a meal, the proportion of short-acting insulin is obviously too large and a different ratio biphasic could be tried. Once children have lost their baby fat, subcutaneous injections are not as easy to give and care must be taken when choosing an injection site. During this period, the abdomen may be a difficult site to use, so injection should be rotated between the thighs and the upper buttock area. Insulin pens have differently sized needles, so that the insulin is delivered directly into the subcutaneous tissue. The specialist nurse will assess a patient for the correct needle size. Vicky was managed as an inpatient over the next few days and was then started on Humulin M3 insulin, 7 units in the morning and 4 units before her evening meal. She was carefully monitored and given a lot of information from members of the multidisciplinary team. After 5 days she was discharged home, but had daily visits from the diabetic nurse for the following 4 days. Question 6 reads, outline a pharmaceutical care plan for Vicky. The pharmacist should contribute to Vicky's overall care and management by providing her and her family with information specifically about storage, administration and monitoring of insulin therapy. It is also essential that the pharmacist reinforce information on all relevant aspects of diabetic care given by other healthcare professionals. The care plan for an individual with type 1 diabetes mellitus must be individualized, as the treatment will affect their whole life. NICE recommends that children be offered an ongoing integrated package of care by a multidisciplinary pediatric diabetic care team, and should have 24-hour access to that team for advice. The key players in this team are the consultant, who will perform the formal clinical assessments of the child, initially on a monthly basis, the specialist nurse, who will have regular contact with the family, and the dietitian, who will be involved initially to advise on diet and then intermittently, depending on Vicky's progress. The key information Vicky and her carers need includes a. Education on how to use an insulin pen device, the easiest initial method of administration. This includes checking the insulin expiry date, using a different needle each time, how to insert, hold and then remove the needle. It is also important that the family know how to use a syringe in case the pen is lost or damaged. b. The need to rotate injection sites, as injecting into the same site can cause lumps to form which will affect insulin uptake in the long term. Rotation guides are available if these are deemed necessary. Patients are normally advised to inject insulin into the subcutaneous tissue of the abdomen, thighs and buttocks in rotation. However, younger children are often reluctant to inject into their abdomen. It is important that no one site is overused, as this may lead to lipohypertrophy and poor insulin absorption, resulting in erratic blood glucose concentrations. The site of injection also influences the speed of absorption, with the abdomen and arms providing quickest absorption and the thighs and buttocks the slowest. More rapid absorption will be caused by exercise or heat, for example from a bath following the injection. Practical instructions for the patient or carer could be as follows. Insulin should be given by subcutaneous injection, i.e. into the fat beneath the skin, not into the muscle. To avoid injecting into the muscle, it is important to lift a skin fold with the thumb and index finger, 2-finger pinch up, and insert the needle at a 45 degrees angle. Lifting a skin fold is important, even if you are using an 8 mm, that is a third an inch needle. With 5 to 6 mm needles, injections can be given without lifting a skin fold if there is enough subcutaneous fat, at least 8 mm, as skin layers may be compressed when injecting perpendicularly. Lean boys, however, usually have less fat, especially on the thigh. Wiggle the needle slightly before injecting. If the tip feels stuck, you have probably reached the muscle. If this is the case, withdraw the needle a little before injecting. You can also inject insulin into the buttocks, where there is usually a layer of subcutaneous fat thick enough to insert the needle perpendicularly without lifting a skin fold. C. How to dispose of needles safely. D. The need to keep spare insulin cartridges in the fridge. Opened insulin can be stored for 1 month out of the fridge. E. how to take blood glucose levels and, hopefully, keep them at 4 to 8 millimoles per liter. A single drop of blood from the side of a finger, not thumb, is usually put onto a test strip. It is important that blood level diaries are kept so that trends can be seen. F. How to assess for hyper and hypoglycemia and how to treat them. It is essential that this aspect of care is understood by all the child's carers, e.g. teachers. If a child has symptoms of hypoglycemia, they should take some sugar or a sugary drink straight away, followed by a sandwich or biscuit. If they are unable to swallow, glucogel, a sugary gel that can be rubbed into the lips or gums, can be used. If these measures do not work, glucagon injections may be given by the carer if they are deemed to have a good level of understanding of their use. Otherwise, the patient and carer should be advised to go to a doctor. It is important that Vicky and her family always carry sugar or sweet food with them. G. Normal dietary advice includes the following. 1. Avoiding fatty foods. 2. Eating mainly vegetables, fruit, cereal, rice and pasta. 3. Eating only small amounts of refined sugar, jam, sweets etc. 4. Eating at regular intervals. And 5. Carrying glucose tablets or sweets in case of hypoglycemia. H. Information on what to do when the child is ill. 1. Have useful contact numbers. Question 7 reads, how should Vicky's therapy be monitored at home after discharge? Initially, blood glucose should be monitored before each meal and at bedtime. This level of monitoring can usually be reduced over time. Immediately following diagnosis, monitoring is essential before each meal along with a final daily check before bedtime. Once glycemic control is stable and appropriate, then monitoring can drop to 2 to 3 times a week, with 3 or 4 tests on each of those days prior to meals, or to twice daily each day to help adherence to blood testing. Monitoring should be increased during acute illness and at times of changed lifestyle. Blood samples are usually taken from finger pricks, although in younger children the heels and the earlobes may provide an alternative site. Blood glucose monitoring must be tailored to an individual's life circumstances, and this is particularly important with children going to school. Enforcing a regimen that is not what the child wants when they are at school, this will vary with age, is likely to lead to a child who carries out no monitoring at all. Ideally, blood glucose levels should be maintained at 4 to 8 millimoles per liter apart from at bedtime, when 7 to 10 millimoles per liter would be ideal. Parents should be taught to monitor as often as possible and to respond to altering glucose concentrations. If glucose levels are high, they may be taught to give additional insulin on top of the normal requirements. This will normally involve doses of short-acting insulin in doses of about 0.1 units per kilogram. These doses should not be given more frequently than 4 hourly to avoid hypoglycemia. If this additional requirement is recurrent, then changes in dose will be recommended. In reality, most additional insulin dose adjustments are made by the diabetic nurse and not taken on fully by the carer. Adjustments of the biphasic insulin dose, whether up or down, are usually made in increments of 10 to 20% of the original. Children are usually monitored, either in the clinic or at home through visits by a specialist diabetic nurse on a regular basis. Initially, home visits may be daily, reducing to weekly over time. The child and their carers will be given dietary advice on avoiding high glucose-containing foods and drinks. They will also be encouraged to fill in glucose diaries so that trends in blood glucose patterns can be seen. Week 5 Vicky was taken to a general practitioner during the family holiday complaining of headaches and nightmares. Her mother admitted that since they had been on holiday they had not been checking her blood sugars as often as they were recommended to, and that they had also missed the last hospital appointment. On top of this, Vicky had probably been running around more than usual on the beach. Her insulin regimen had not altered much over the first few weeks, and from her last consultation was still 7 units of Humulin M3 in the morning and 4 units in the evening. Her mother was also concerned that Vicky's eating habits had become more erratic, even before the holiday, and was not sure of the consequences of this. Question 8 reads, "What do the presenting symptoms tell us about Vicky's condition?" That Vicky is being overtreated with insulin and is suffering from hypoglycemia. Nightmares, as in Vicky's case, poor sleep and crying are all potential signs of hypoglycemia. Hypoglycemia is a very serious and life-threatening consequence of diabetic treatment. It is particularly hard to spot in children and is more likely to occur as a result of their very varied activity levels throughout a day. Nocturnal hypoglycemia has also been observed more frequently in children than in adults and, perhaps more worryingly, it is often asymptomatic. Question 9 reads, "Why is it so important to keep a close eye on blood sugar levels in the first few months after starting treatment?" A lot of patients have a honeymoon period for the first few months after starting treatment, with their insulin requirements dropping off dramatically. Apart from the lack of sugar monitoring that Vicky has been receiving and the increased exercise burning off more sugar, she is at increased risk in the first few months after diagnosis of having lower insulin requirements. Around a quarter of all patients who develop type 1 diabetes mellitus have what is known as a honeymoon period within days or weeks of the onset of treatment. It is as if the patient has gone into remission, and it can be confusing for the patient or carer as it would appear that the condition has corrected itself. Some patients actually require no insulin during this phase, and this may last for weeks or months. It is usually best to keep treating with insulin, even if the requirements are negligible, to avoid possible insulin allergy upon re-exposure, and also to maintain a treatment regimen and not give false hope to the patient. Question 10 reads, "What treatment changes would you recommend for Vicky?" Vicky now needs increased monitoring and probably a reduction in her insulin dose, especially in the evening. The nightmares indicate that the hypoglycemia is occurring at night, but increased daily monitoring should be encouraged to rule out an overall honeymoon period. Both bedtime and early morning blood glucose monitoring should be carried out. It is important to have a good picture of what is happening to ensure the best changes to treatment. If a biphasic insulin is being given before the evening meal, the overall dose may be too large, or perhaps the soluble insulin component needs altering. The most common treatment change to avoid nocturnal hypoglycemia is to use a different ratio of biphasic insulin, such as 75:25, e.g. Insulin COM 25, thereby reducing the amount of fast-acting insulin. The use of biphasic insulin containing a very fast-acting phase, such as Humalog Mix 25, could also be considered, as the action of the Lispro insulin is short-lived. Alternatively, control may be almost correct and the only intervention needed is to give a small snack just before going to bed to keep the blood sugar up. Question 11 reads, "What are the possible options for treating type 1 diabetes mellitus in children with erratic eating habits?" The answer to this is very patient-specific. but may involve giving short-acting insulin more frequently, that is, 3 times daily, and an intermediate-acting insulin before bed. Set regimen and combination, i.e. biphasic, insulins are the most convenient form to administer, provided the person's lifestyle and eating habits do not fluctuate greatly. Children are renowned for eating erratically, and for the quantity and content of what they eat having little to do with their daily routine, or lack of it. Using the same total daily insulin dose, the soluble insulin may be given before the 3 main meals of the day, i.e., breakfast, lunch and dinner. A 4th dose of intermediate insulin is then given prior to going to bed. Another option could be to use insulin lispro as the short-acting insulin in the above regimen. It is fast-acting, onset in about 15 minutes, peaking at 1 hour, with a short duration, i.e., about 5 hours, and can solve some of these problems as it can be used when necessary and will even be effective if given directly after a meal, instead of before. In reality, erratic eating habits often go hand in hand with poor adherence, and education is the main support of treatment. See answer 15. Vicky was discharged after another long consultation with the pediatrician and diabetic nurse. Her insulin type had not been changed, but the dose had been reduced to 4 units in the morning and 3 at night. Over the next few months, Vicky was not a regular clinic attender and her blood sugar diary was not well filled in. However, she did remain fairly well. Month 6, Day 1, Vicky was once again brought back to accident and emergency department by her mother. She was looking very pale and lethargic. She had been unwell for a few days with diarrhea and vomiting following a friend's birthday party. Her mother said they had omitted the last couple of doses of insulin as Vicky had not been eating, but that she had carried on going downhill. On examination, Vicky was very lethargic, but just about responding. Her eyes looked sunken and her mouth was very dry. There was a distinctive fruity odor on her breath. Her abdomen was very tender and her pulse rate high, at 125 beats per minute. She was breathing deeply. Her laboratory results were as listed below. Blood glucose 25 millimoles per liter. The reference range is 3.5 to 10 millimoles per liter. Creatinine 180 micromoles per liter. The reference range is 80 to 120 micromoles per liter. Sodium 150 millimoles per liter. The reference range is 135 to 147 millimoles per liter. Potassium 5.6 millimoles per liter. The reference range is 3.5 to 5.0 millimoles per liter. Chloride 110 millimoles per liter. The reference range is 95 to 105 millimoles per liter. Bicarbonate 5 millimoles per liter. The reference range is 22 to 29 millimoles per liter. Urine 2% glucose and ketones, that normal value for both is 0. Weight 21.2 kilograms, last recorded weight was 23 kilograms a month ago. Vicky's therapy had not varied greatly over the last few months, and her last regimen had still been using Humulin M3 at a dose of 4 units in the morning and 3 units at night. Question 12 reads, what is the clinical diagnosis for Vicky? Vicky has acute, life-threatening diabetic ketoacidosis. As in the initial diagnosis, Vicky has signs of ketoacidosis. However, this time the signs and symptoms, as well as the laboratory results, show that it is serious and potentially life-threatening. Vicky has presented with a high blood glucose level, which in turn has led to an increase in plasma osmolarity. Osmotic diuresis has then set in, with loss of fluid and electrolytes. Dehydration can be rapid, causing changes in skin texture, sunken eyeballs, and eventually loss of consciousness. Excessive ketone production causes a distinctive fruity odor on the breath. High levels of ketones also cause a fall in pH, as they are organic acids. Hypercapnia then results, owing to the respiratory rate increasing to try to compensate for the metabolic acidosis. Question 13 reads, why might this have occurred? This occurred due to misinterpretation of her symptoms, leading to non-administration of insulin. Vicky was vomiting after the party. It could be assumed that she had gastroenteritis and thus was not eating, and therefore would not be needing any insulin. In reality, the nausea and vomiting were probably the first signs of ketoacidosis due to a large glucose intake at the party. Non-administration of the insulin has only made the situation worse, and has caused a critical ketoacidosis to develop. Question 14 reads, what are the aims of treatment now? The main aims of treatment for Vicky are to correct her dehydration and the hyperglycemia. Question 15 reads, what treatment would you recommend for Vicky? Fluid correction is vital and must be initiated immediately. This must be done cautiously, while bringing the blood sugars back under control. Children who are more than 5% dehydrated and/or drowsy will almost certainly require urgent IV fluids with electrolyte correction. However, this must be done with caution to avoid cerebral edema and hyperkalemia, which are the leading causes of death in such cases. Vicky is 1.8 kilograms lighter than she was a month ago and has therefore lost about 8% of her body weight through dehydration. Weight loss should be based, as near as possible, on her current weight against her weight before dehydration started. This is severe dehydration, with 1 kilogram weight loss equating to 1 liter of fluid loss. Treatment will be as if the dehydration were 8%. As using figures higher than this can lead to more complications and assessment can never be regarded as totally accurate. In cases of greater than 5% dehydration with shock, or in the young, it would be normal practice to treat the patient on a pediatric intensive care unit. Children who are in shock due to the severity of the ketoacidosis, tachycardia, poor capillary refill time and hypotension, should initially be given 10 ml per kilogram of sodium chloride 0.9%. Vicky has some of these symptoms, and this should be the first treatment that she receives. After this initial fluid, a continuous rehydration infusion should be set up alongside an insulin infusion. The rehydration regimen should be calculated so that fluid correction takes place over 48 hours as follows. 24-hour correction is equal to maintenance fluid plus 0.5 multiplied by deficit plus any continuing losses, e.g. vomiting. Maintenance is equal to the following. For 0 to 2 years, 80 ml per kilogram per 24 hours. 3 to 5 years, 70 ml per kilogram per 24 hours. 6 to 9 years, 60 ml per kilogram per 24 hours. 10 to 14 years, 50 ml per kilogram per 24 hours. Greater than 15 years, 35 ml per kilogram per 24 hours. Deficit in ml is equal to percent dehydration multiplied by body weight in kilogram multiplied by 1000. For Vicky, maintenance is equal to 60 ml multiplied by 23 kilograms, which is equal to 1380 ml per 24 hours. Deficit is equal to 8 divided by 100 multiplied by 23 multiplied by 1000, which is equal to 1840 milliliters. Thus, 24-hour correction for Vicky is equal to maintenance plus 0.5 multiplied by deficit, which is equal to 1,380 ml plus 920 ml, which is equal to 2,300 ml, i.e. 4.6 liters needs to be run in over the next 48 hours. Provided she is not anuric, which she is not, this fluid should be sodium chloride 0.9% with 20 millimoles of potassium in each 500 ml bag. An electrocardiogram monitor should be set up and her potassium levels should be checked every 2 to 4 hours throughout the first 24 hours. Levels should be corrected to keep them between 4 and 5 millimoles per liter. The insulin regimen should be as follows. A continuous infusion of soluble insulin, Actrapid, should be set up. The insulin should be diluted to 1 unit per milliliter in a syringe using sodium chloride 0.9%. The infusion should be started at 0.1 units per kilogram per hour. If the rate of fall of glucose is greater than 5 millimoles per hour, add glucose to the IV fluids, then the rate of the infusion should be halved. Rates of fall is greater than 5 millimoles per hour can lead to large osmolarity changes, and this can in turn lead to cerebral edema. When the blood glucose is 14 to 17 millimoles per liter, the insulin infusion should be reduced and the fluid changed to glucose 5% plus sodium chloride 0.9% with or without potassium, still running at the same rate. Blood glucose levels should be held between 10 and 11 millimoles per liter. If levels start to dip below 7 millimoles per liter, the glucose input should be increased. The insulin should not be stopped, as insulin is required to switch off ketone production. Acidosis is usually self-limiting. However, profound acidosis with a pH less than 7 with shock and circulatory failure will require sodium bicarbonate infusion to reverse the acidosis slowly. This should be a very rare requirement if rehydration has been managed appropriately. On day 2 after 36 hours, Vicky was able to tolerate oral feeds. On day 3 her fluid balance and electrolytes were finally completely corrected. She was given the first dose of her usual subcutaneous insulin an hour before her insulin infusion was turned off. Because of the recent problems and a real loss of confidence in the treatment regimen on the part of Vicky and her mother, a thorough review was conducted by the consultant and specialist nurse. The options were discussed with Vicky and her mother, and included the use of insulin glargine, Lispro and insulin pumps. However, it was decided that she would be better off at this time carrying on with the twice-daily biphasic insulin with regular support from the diabetic nurse. Question 16 reads, discuss the advantages and disadvantages associated with alternative methods and types of insulin. Why is it likely that the current regimen was finally decided on? Alternative methods do have their advantages, but they are generally felt to be best suited to patients with a thorough understanding of their disease state and a high level of motivation. This is not the case with Vicky and her family, so continuing with the current regimen is the best option here. Insulin glargine and detamir are long-acting insulin analogs. They are designed to have a flat release profile to mimic natural insulin release and have a longer duration of action than isophane insulin. A lower incidence of nocturnal hypoglycemia has been demonstrated in some trials, although early morning hypoglycemia may occur. Short-acting insulins still need to be administered before meals, and thus the number of injections daily is likely to be 4 or 5, making it less convenient for patients with poor adherence. Insulin pumps are available and being reviewed for their place in therapy as they provide an alternative to multiple injections. The insulin pump is a battery-operated pump with a computer that programs the delivery of predetermined amounts of soluble insulin from a chamber into a subcutaneously implanted catheter. The pump can deliver a constant flow as well as be activated for boluses by the operator 30 minutes before meals. Lispro insulin is also now being combined with the pumps so that shots of insulin can be given whenever a meal is eaten, rather than the user having to pre-plan and inject 30 minutes before meals. This type of device is likely to increase in use, as it can mimic normal insulin flow reasonably well. However, users must be highly motivated to use the device efficiently, and not all children take kindly to having a pump attached to them. This may well be a suitable device in the future for Vicky. Vicky and her family are typical in terms of compliance with the treatment of type 1 diabetes mellitus. The best way to improve treatment is to continuously encourage adherence and to reach agreement about treatment which takes into account the social issues. Question 17 reads, how should Vicky's mother be advised to manage minor illness in the future? Vicky's mother should be advised never to stop giving insulin to her daughter even if she is unwell and not eating. Even when she is unwell and not eating, Vicky's body is still producing glucose from its stores. If the insulin is stopped, then Vicky could become hyperglycemic and seriously ill. The dose of insulin may need to be adjusted during periods of illness, and thus careful monitoring of the patient is essential. Blood sugars usually rise during illness, especially if fever is involved, and thus increases in insulin may be necessary. This increase in requirements is usually short-lived and reductions will need to be made as soon as levels start dropping again. Increased requirements are usually only in the region of 10 to 20% of the original dose. Hyperglycemia is more common if dehydration occurs, and this is common during episodes of fever. Therefore, good fluid intake should be encouraged throughout the day. If solid foods are not being taken, then alternatives such as milk, fruit juice, soup, ice cream and fizzy drinks will help maintain the carbohydrate allowance, thereby avoiding hypoglycemia. During illness, the urine should be monitored for sugar and ketones. The presence of both of these substances will indicate a lack of insulin. If there is no sugar and only ketones, this is an indication of lack of food intake, especially carbohydrates. Vicky's mother should be advised to contact the healthcare team for advice during periods of illness. Question 18 reads, how should Vicky's specialist consultant and general practitioner monitor her long-term therapy? Alongside the blood glucose and HbA1c monitoring, there are a number of other parameters that should be monitored regularly. These include growth and development, injection site checks and retinal field checks. At this age, growth and development must be plotted regularly on a standard growth chart. It is important that the injection sites are checked to ensure that they are being rotated. If sites are used over and over again, they may become red and lumpy, a condition called lipodystrophy. Insulin injected into these sites may not work properly, owing to poor absorption. Because of the long-term risk of retinal damage, eye checks should be performed not only at initial diagnosis, but also on a yearly basis thereafter. This practice usually only starts once the child is 12 years old. But many clinicians will do random eye checks before this time, especially if diagnosis is at a very early age.
Thank you.